I'm going to continue my podcast series talking about those transgender patients that transitioned socially as children. Last week, I talked about that social transition. Now I'm going to talk about that medical transition. So, as they grow up, as they age, as they enter puberty, what is the option for medical transition for those that choose that transition? So, what I'm going to talk about is how entering that phase for those that desire a medical transition, because not everyone will, but those that desire medical transition, how that looks different entering that medical treatment compared to those that went through a puberty already and are going to go through a second puberty with their medical transition. We're going to talk about how those things are different. We're going to give a baseline of what that medical transition looks like, just a baseline knowledge, because as physicians, it's important that we have some concept. We don't need to know dosing and what needs to be monitored and things like that. We just need to have a general idea of what that looks like we do for most things in medicine. And then we're going to talk about decision making. How are those decisions made? How is that carried out? What are special considerations? So let's get started with what looks different. When a patient is deciding on a medical transition, a patient that transitioned earlier in life socially, there are some differences. Now, one thing I did not mention in the last episode that I want to mention now that I heard a lot of comments about was that children that socially transition, there's an idea like the decision is made on a dime. Like a kid says, I'm a boy and they're a boy, and that's that. And it doesn't usually occur that way. Now, we could talk about whether it should or shouldn't, doesn't matter. It doesn't normally occur that way. Many families I talk to, it's usually an evolution. It is certain things that they may notice, certain behaviors, but most of it they realize in hindsight. For example, one of the stories that I had the privilege of sharing with you is that there was a child who was designated male at birth. And when they were like 3 or 4 years old, they oftentimes would um, take a shirt and put it on their head and wear it like long hair and pretend to have long hair. If there was dress up where there was anything that society would consider feminine, like dresses and fairies, they would often choose those things to wear. And I just want to point out that those things alone does not mean that a child is transgender at all, that there can be normal gender exploration. And that's what the parents just kind of thought it was and didn't think a lot of it. But we're just noticing this pattern that when the child needed a haircut, she would put up a real big stink about it. She would be so distressed every time they cut her hair and they didn't understand why, and they did it anyway. And then when Halloween came, she wanted to dress up as what was traditionally a female character. But again, the parents just thought it was exploration or kids like what they like. And these weren't things that made them think that the child was transgender, but they're noticing this pattern. And they still waited until the day when the child mentioned that they wanted to cut their penis off because they were a girl and asked, why did God give this to them? And it was at that moment that the parents thought, we need to have some discussions. Our child is in distress. Let's create some support. They didn't immediately say this child's transgender, this child's a girl, but they sought out help. Did some research. They talked to the child in a very open manner of like, tell us more, open questions to begin to understand what was going on. And this, like many other stories, evolves over time. Maybe there's a change of a name. Maybe there's a change of pronouns. Maybe there's a change of clothing. Maybe it's let me grow my hair. Whatever it is, it's just following and seeing what happens. There's no big decisions being made. It happens over time. So I wanted to say that these decisions aren't made on a dime. And so this is the other thing is that time has passed. The child has demonstrated through words, through living, etc., how they identify as they come into a medical transition. Again, I'm talking about a very specific subset of patients. They come in to their medical transition having lived their life and being affirmed. And that idea of being affirmed by their families also leads them in a different position. They tend to be happier. They tend to be happier because they're not dealing with the fear of coming out to their families. They've already come out. They're not dealing with wondering if they're going to be kicked out of the house or supported. They're living at home supported. They're living their lives as their true selves. They've had that experience. And so when they're going into a medical transition, they tend to be happier. And I bring this up because there are a lot of studies, good studies, that look at the depression rates and suicide rates before and after medical treatment or compared to those that don't get medical treatment that want it. And there's often a great change between when they start and later. I wouldn't expect to see that change in this group of patients because they're coming into that medical transition, if that's what they choose, if that's what they want, already happy, already supported, already affirmed, not worrying about any of those things that many adolescents have to worry about when they're coming out later. So they're coming into this happier. The other thing is they're often coming into their medical transition with knowledge, with understanding. There was a story of this one boy who was assigned female at birth that was elementary school age. And his mom was saying that they were sitting watching TV, and he had transitioned like a year or so before. They were sitting there watching TV, and in the middle, just out of nowhere, it's like, I do not want those. And she looked at him and said, what are you talking about? And he pointed at her chest and said, I do not want those. I do not want to grow those. And he was referring to her breasts. So that was an indication of an awareness. And many conversations like that do occur where parents don't necessarily need to bring it up. The kid's already worried. So many times there can be discussions about, like with that family, I believe the parent said something to the effect of, well, you don't need to worry about that right now. Right now, you are growing, and that is what your body is busy doing, is growing. And when it gets to the point where it needs to change to its adult form, if you still feel that way, there are things that can be done. And they just left it at that. And that seemed to settle that child's anxiousness with that answer. But my point is many times these kids are aware that there may be something if, because not everyone wants the same thing for their body, but many of them are made aware that if that's the case, there is something to be done. And so again, coming into puberty with less angst, less anxiety. And so I think that's important to remember. That doesn't mean they want their body a certain way or that they're completely fine with the way it is. They've just had reassurance and affirmation. So that's a little bit of the difference. Now, when we talk about the medical treatment, what that looks like, the first thing I have to say, which I know I've mentioned, but I want to make it very clear that every transgender and non binary youth does not necessarily want a medical transition or medical gender affirming care. So that's the first thing to mention. But for those that do, what typically happens is that they have to begin puberty. So I think sometimes I hear some misinformation that they don't even know what their puberty is like, they should experience it, so forth. They do have to go to Tanner stage 2. So we do break up puberty into what we call the Tanner stages, and they have to get to Tanner stage 2. Once they've gotten to Tanner stage 2, then we discuss puberty blockers. Puberty blockers do exactly what it sounds. They are GnRH agonists that pause puberty. And when I say that they are reversible, what I mean is that when you remove them, puberty will continue on. So they're reversible in the sense that we stop puberty, and when you remove them, puberty will continue on. And they're a medication that is used in other children. It's medication used in precocious puberty, meaning children that start puberty early. Same thing, even though the body is programmed to start puberty at an early age, say 6 years old, it is used to pause puberty and give that child more time. And that's the same thing that's being done here is it is giving the adolescent more time, a little bit of a pause to gather information, to understand, to develop, to clearly make a decision before anything irreversible happens. And I'll talk about that next. In the French consensus, what came out last November, that the country of France came out with a consensus of how they're going to handle gender affirming care. And when they talked about puberty blockers, they talked about the benefit, the psychosocial benefit of allowing for that pause, of giving time for that pause. So there's a lot of benefits to that pause. It's a time that many times can be used for education too, to give time and space for the education over puberty, endogenous puberty versus exogenous puberty, testosterone driven puberty versus an estrogen driven puberty. So that is the next phase. The next phase, when it is time and how that's decided, is a multitude of factors that I'm not going to go into. When I give grand rounds, I have more time to talk about these things and go more into the data and the research. But for these purposes and trying to keep under 30 minutes, I will say cross sex hormones, which is estrogen and testosterone, are the next step. And as I mentioned, those are irreversible, meaning that once you give them, some of the changes that occur are not reversible. So with estrogen, one of those changes that can occur is chest development. With testosterone, one of the irreversible changes is facial hair or deepening of the voice. Now, I want to point out that those changes are irreversible, whether it's an endogenous puberty, meaning you allow the body to go through the puberty for which it's programmed, or whether you give hormones and go through that puberty. Either way, they're irreversible changes. And I bring this up because it's often mentioned, well, if you give somebody estrogen, if you give somebody testosterone, they're irreversible changes. Absolutely. And if you don't, they are also irreversible changes. Puberty leads to irreversible changes. That's what I'm saying. The beauty of the puberty blockers and giving that pause before any irreversible changes occur, it gives you chance to educate and think and decide for that patient, for that adolescent to be aware what is in alignment with me, with who I am, before endogenous or exogenous puberty occurs. So, either way, it's irreversible. The other consideration I do want to say with hormone treatment, and the reason why the idea of waiting till someone's 18 is not really a great idea, is we think about pure concordance. So puberty blocker stops puberty. They're just not going through puberty. And pure concordance, what that means is that when is everyone else their age going through puberty? Now, the other youth, the other adolescents that might get estrogen and testosterone who are not transgender are those that have delayed puberty, I mean, puberty hasn't begun. And there are papers showing some of the distress that those patients with delayed puberty undergo because of it, because of not having pure concordance, because not going through puberty till much later than their peers. There's evidence of depression, there's evidence of bullying, there's evidence of social isolation. And so, for that reason, that's why some of the protocols were created for delayed puberty to be given estrogen, testosterone to give kind of a jump start to puberty. Same idea here is because if we know that there are negative effects to having puberty when your peers are not, that is the benefit of starting some of these hormones. It doesn't have to be at the start, obviously, we created that pause, but we're trying to get it at the time where, and maybe at the later end of that time, but somewhere in that time where their peers are going through puberty too, for the best outcomes for the patient. So, the last thing I said I'd mention is the medical decision making. So many times this is discussed as if it's done on a whim, as if it's, oh, a kid can just say and a kid doesn't know and all this stuff. And the decision for a medical transition is made as a team. Let's say that again. The decision for a medical transition is made as a team, meaning that it's the patient, that it's the parents and guardians, that it is the physician, that if there's any sort of support, like a therapist, all of these people work together to discuss and decide what is best for the patient. It is a group decision. A child alone may initiate and say, this is who I am and this is what feels in alignment with me. But that alone does not decide the medical transition. It is a team decision. Now, you may say an adolescent is initiating it. Do they really have the capabilities of knowing? And then there's often examples of bad decisions in adolescence and so forth and so on. But there are some research papers that do show when it comes to gender affirming care, transgender youth, most of them, not all, there's no always and nevers, most of them are very good at making the decision, especially when they have had a chance to process the information over time. Whether that is they've been doing their research on their own and studying and learning before they seek medical care, or in the case of these patients that transitioned early on, that they have been receiving the information and knowledge along the way. During that pause of puberty blockers, it is believed that they are able to make decisions that are not affected by impulse and by peers, etc. And the other part is that this decision is made by informed consent. That means explaining what the risks and benefits are to treatment, just like we do with anything else, and allowing the patient and the family and the team to decide. And I want to tell you that one of the things that often comes up is the issue of infertility and the concern for infertility. And it's often talked about as if these families have not thought about it. I want to tell you that most families that talk to me before they're about to start a medical transition, one of the biggest concerns I hear about, one of the topics that is discussed the most with me is about infertility. Families often want to talk about this decision that they feel like they're making about their child's fertility. Now, I just want to say there's not research. We don't know what the effect of fertility is. Like, if in X number of years the patient decides to come off cross sex hormones and go through an endogenous puberty, what the effect will be on fertility. We don't know. We are making our best guess based on physiological knowledge and basis, but we don't know. Most likely, based on our best guess, there will be infertility, but will that be 100%? Will that be 75% of patients? Will it be 50%? Will it be 90%? Like, we don't know. And so that's important to explain, but that the decision needs to be made with eyes wide open that this may lead to infertility in the long run. Again, best guess, not research based. And it's the hardest part, I think, of the decision when I hear from parents. But like anything else in medicine, it's risk benefit. What is the risk of offering the treatment? What is the benefit of offering the treatment? And it is from there that patients make their decision. It is from there is the reason we offer the treatment because of the risk benefit. The fact that we know there for those patients, for those adolescents that desire gender affirming hormones, there is a decrease in depression, there is a decrease in suicidality. So, weighing that benefit. Now, I want to say something about the suicidality because I've heard some people say, like, oh, a teenager threatens you and you just give in. No, that's not what we're talking about here. When we talk about the suicide risk with gender dysphoria, for not treating it, we're not talking because all these teenagers are threatening it. Not at all. We're talking about the natural history. For those that aren't in healthcare, when we talk about the natural history of something, it means what happens if you don't do anything. What happens if you don't treat? That's referred to as the natural history. And the natural history of gender dysphoria, one potential outcome is suicide. So, no, we're not talking about a response to threats. We're talking about considering the natural history. Lastly, I can't talk about medical treatment without pointing one very unusual thing about this. And that is, this is a medical treatment, a non-psychiatric medical treatment. The puberty blockers, the cross-sex hormones. It's a non-psychiatric medical treatment. It is the only one in that category that requires a psychiatric diagnosis. You have to have a psychiatric diagnosis, gender dysphoria, in order to have a medical endocrine treatment. I just give you that to think about. Why is that? How do you think that plays on our biases and psyches? What about these patients in particular that I am talking about that often, yes, may have some dysphoria, but not in the ways because they're living affirmed, they're living knowing options for those that have them accessible to them? Just something to think about. But what I do know, and this is anecdotal, I told you I always tell you the difference when I'm talking research and when I'm talking my own personal experience from the kids I've met. They're not kids. A lot of them are adults now. And the ones that I know and have met are happy and well adjusted. They know who they are, all of who they are. Yes, they're transgender, they're non binary, and they know all other aspects of themselves, all aspects of their identities. They live very full lives because they've been affirmed and allowed to be their true self and loved for it unconditionally. And the medical transition has further allowed them to be their true selves in alignment with who they know themselves to be. And that is why medical transition matters.